The Safe Airway Society, or SAS, is the interprofessional airway society for Australia and New Zealand. Our members come from a wide variety of health professions. From the outset, we've tried to include everybody that's involved in airway management, but we also represent patients and their families. And we feel like that makes us unique amongst airway societies worldwide.
There are three main reasons why SAS has been created. And in 3 words, that's connection, collaboration and patient safety. So in terms of connection, we recognise that within and across Australia and New Zealand we have some quite unique geographical challenges of distance and environment. What we aim to do and achieve is to connect people from all corners of Australia and New Zealand.
Which leads us to the next reason, being collaboration, and it's a collaboration of professions, a collaboration of skills, knowledge and expertise, collaboration in research and education, and that kind of takes us to the main reason, being patient safety. So we're there primarily to promote airway management and safe practices in airway management, regardless of your profession or where you work.
Historically, airway management was really the remit of the anaesthetist, but contemporary medicine, airway management is occurring all over the hospital and pre-hospitally, so critical care clinicians are intubating patients in the intensive care unit, emergency physicians in the emergency department, and then either pre-hospital clinicians or paramedics in the pre-hospital environment. The concept of SAS is really the idea of cross-pollination and bringing the expertise from all those different interprofessional groups to promote best airway practice in all the settings that it can occur.
Overall, airway management is very safe and effective. However, there are still incidents now where patients can get seriously injured or even die. What we want to do is create an environment where safe and effective airway management is delivered to all patients. The way we're hoping to do that is to create better resources, to improve the existing systems that we've got already, and also through education and research. So we want to look at how we work as humans, as well as how we work together as a team.
A complex healthcare challenge needs an interprofessional collaborative approach. Join us at safeairwaysociety.org.
Welcome back to session 2.3, where we remain in the emergency department, but we're going to shift our focus to discussing complex airway techniques. In the last session, we talked mainly about determining how urgently that patient needs to be managed, and we discussed that urgency assessment was based primarily on patient factors. In this session, we're going to explore what techniques you might use based on that urgency assessment and the impact that team and situational factors are going to influence where you can use these techniques. We have a truly international panel again in this session, and I'm really looking forward to the discussion. We welcome back ED physician John Sackles and ENT surgeon Reza Nurai from the last session, and we're also joined by Chris Groombridge, an emergency physician and trauma consultant from the Alfred Hospital in Melbourne, who we met during session 1. For the purpose of the discussion, let's describe what we mean by a complex airway technique. I don't think this is particularly straightforward to define, so perhaps it's better to discuss in terms of the types of techniques that would and wouldn't meet this definition. Given the accessibility and training in video laryngoscopy, even hyperangulated blade video laryngoscopy, I don't know that in 2021 I would consider that to be a complex airway technique, but I would consider complex anything involving an awake patient, anything involving specialised equipment like a flexible bronchoscope, and anything involving a surgical technique. In this session, we'll focus on a discussion about which complex techniques can be possible in the emergency department and barriers that might exist to performing these complex techniques in the emergency department, as well as discussing some things that can be used to buy time, either prior to using a complex airway technique within the ED or before moving the patient to another location. So get back to our patient. He remains with the same clinical features as in the previous session. He remains stridulous. He remains reluctant to lie flat. He's mildly dyspneic, and he has oxygen saturations of 92% on a non-rebreathing mask. And I think we can all agree, and commentary from NAT4 would support this view, that moving a patient with a threatened airway is associated with risk. So in an ideal world, you'd secure the airway before getting that patient into a lift or before moving them to another location. But we also have to recognise that in many centres that's just not possible because of environmental, equipment and team factors. John, I'm going to start with you in this session. After watching your presentation on awake tracheal intubation, it sounded to me that many of these complex airway techniques are possible in your emergency department. And I wonder if you could outline what can and what does happen in your ED.
Right, so the introduction of video laryngoscopy and now flexible video scopes that plug into the video laryngoscopy system has been a real game changer. In the past, when I needed to do awake fiber optic intubation, it would require getting a card out with an optical light source, a video processor, monitors, a whole big cart. And now both Karl Storz's CMAC and Verathon's GlideScope both have flexible scopes that plug into those systems. So now it's very easy to perform flexible intubation in the emergency department because the equipment we need is minimal. All you need is a flexible scope, and if you have the GlideScope system or the CMAC system, it plugs into the same monitor. And now actually you can do dual camera intubations because you can actually see the rigid video laryngoscope and the flexible scope on the same screen. So I think now with the current technology, it's very feasible for emergency departments to have the equipment necessary to do these complex intubations in the emergency department.
So not only video laryngoscopy and flexible bronchoscopy awake, but the combination of both is accessible, at least in your emergency department, John. Chris, you work at one of the busiest trauma centres in Australia, and I've got a two-part question for you. Does the access to these complex techniques differ in your emergency department? And, you know, considering away from the Alfred, what's your impression of access to complex techniques in Australian emergency departments in general?
Sure. I think it's fair to say that these techniques are rarely performed. So we run an audit and have done for the last 4 years, and I can only think of 2 intubations that involved a fibroscope being done down in the ED. I know that our intensivists are actually working with this technique, so they do a number of intubations where they use both the hyperangulated laryngoscope and the bronchoscope, and the intensive care unit's only 1 flight above us in the lift, and so they would come down and give us a hand. And actually we had a very similar case to the one presented recently in our ED where the anaesthetist was called straight away. We didn't feel like it was time for them to go to the theatre, and so we actually got them to bring the bronchoscope down, and they performed that same technique with a hyperangulated video laryngoscope and the bronchoscope guiding the ETT intratracheal. So I think it's fair to say that emergency physicians in my department, and I'm pretty sure across Victoria, are not performing these techniques, but we do have experts that can come and perform them. Just one additional thing to say, that in the list you mentioned surgical airway, and I think it's fair to say that it's a skill set that emergency physicians do tend to have. And so in our audit, there's been 4 surgical airways in the last 4 years, and they were all performed with a team approach, but the actual surgical airway itself was performed by the emergency physician in the team. So that of the 3 techniques, that would be one that would be performed in the ED. Yep.
Thanks, Chris. So look, if these complex techniques, and perhaps if we just focus for a moment on awake bronchoscopic intubation, if they are, I guess, rarely performed in emergency departments in Australia, what do you think the barriers are to accessing these complex techniques? Is it equipment? Is it training? Is it environment? Is it a combination of all of those factors?
Yeah, I think it's a combination of those factors. I guess we don't have a bronchoscope. The disposable equipment is becoming cheaper, and it comes up a lot in our consultant meetings about whether we can start using this equipment, because we could use it for nasal endoscopy. We've even run a trial where we use those scopes to insert chest drains. And so there is some appetite for getting these devices into the department. And in fact, as part of the airway course, we teach intubation through a supraglottic airway using one of these disposable devices. So there's a lot of appetite for it, but currently the kit just isn't readily available. It's quite expensive, and we don't have the ready-made bronchoscope stacks ready to go like they do kind of ready to go in the intensive care unit or in theatre. So I think that's probably the main thing is the cost. Certainly you could upskill the team, but it would be a big leap to doing it to a fibre optic awake intubation. But I certainly think techniques like through a supraglottic airway is much more straightforward and could be amenable to training.
So I guess if we come back to the statement or the ideal I raised earlier, that if we don't ideally want to move this patient until we've secured their airway, do we need to set up our EDs? Do we need to look at least having access to flexible bronchoscopes in the emergency department, even if that does involve, as you mentioned, at least initially, perhaps the intensive care doctors or the anaesthetists coming to assist and all be involved. Is this something in 2021 in Australia and New Zealand that we need to explore?
I agree. I think that it is, and so practically speaking, what I would do is I would try and get as much ready as possible in the ED and make an immediate phone call to the anaesthetic CIC and say, essentially, this is a very brief summary. Please could you start walking towards the ED with a bronchoscope? I think it's very unrealistic to move the patient towards theatre in this setting. You really underestimate how long it takes to get there. I think I would make that phone call straight away and they would start walking towards the ED. We have a difficult airway trolley that's set up to mimic the one in theatre, so things like oversapien airways, all the things that you might hope to find when you get down there will be there, but I want you to bring the bronchoscope with you because there isn't one when you get here.
Yeah, and as you said, perhaps some of the barriers to having bronchoscopes readily available in locations outside of theatre in the past really related to the expense of the equipment that was reusable, and perhaps with the advent of disposable scopes, that might be at least one barrier that can be relatively more easily overcome. John, just coming back to a comment that you made in your presentation, and you alluded to it just before as well. John, you discussed that awake tracheal intubation is a technique, not a device. And correct me if I'm wrong, but I think you mentioned that current, in your practice now, awake intubation may just as commonly involve a video laryngoscope as it does a flexible bronchoscope.
Historically, the only device we had for awake intubation was a flexible scope. But now with rigid video laryngoscopes, it's reasonable to use a video laryngoscope on some of these patients with difficult airways, depending on what the anatomical issues are. So I think rigid video laryngoscopy is a very reasonable approach to awake intubation. And actually, I'm a big fan of the combination of a rigid video laryngoscope and the flexible scope, the dual technique, where both are on the screen there for some of these patients.
Thanks, John. Reza, I want to come back to something that we touched on in the last session, acknowledging that we don't all work in emergency departments like John or like Chris for that matter. Coming back to the options to perhaps buy time in this patient so that you do have the option to hopefully stabilise and move them if preferred, and if you don't have the ability to perform a complex airway technique in your emergency department. Did I hear correctly from the last session that you would be very comfortable using something like high flow nasal oxygen in this patient, and are there other techniques that we can use to help buy time?
Right, thank you. Yes. In my thinking, I think of airway and cervical spine protection, breathing and high flow nasal oxygen, circulation and hemorrhage control. So I'm strongly in favor of using Optiflow high flow nasal oxygen in that situation. If we consider the physiology, 50% of the total resistance of the respiratory system happens between the nose and the larynx. And actually the opening of the larynx itself accounts for 25% of the entire respiratory resistance. In a traumatic situation, more so. Having a nasal high flow vortex that effectively bypasses this through the nose, above the larynx. And actually, when you look at the physiology of it, there isn't a big blast of things going into the airway and then coming out of the nose. You're effectively reducing the resistance of the respiratory system by 50% in an awake patient, whilst you are improving the patient's oxygenation and reducing collapsibility of a traumatized airway.
We may just have momentarily lost Reza there, and we will do our very best to get back to him, because I certainly want to hear about some more techniques that I can use to buy time in this patient in front of me whilst we're mobilising some other resources. I wonder if we might be able to see if there are any questions coming through from the audience. If you haven't yet submitted your questions, please do so. I've certainly got a couple of questions that I'd like to know from our panel members, particularly John and Chris, who work in the emergency department and who are, you know, on a regular basis needing to manage patients with traumatic airway injuries like this. Are we able to see any audience questions at the moment, Nick?
Yeah, I've got a question for John. He mentioned features depending on the anatomy. John, you mentioned that whether you would choose videolaryngoscopy or tracheal intubation, and the question is just what features would make you choose between those two techniques? What makes you favour? Between using a flexible bronchoscope and using a rigid laryngoscope for an awake technique. What features would make you lean towards one or the other?
Well, I guess it mostly has to do with the structural anatomy that you're dealing with. If you're dealing with a big tongue or some symmetric process, rigid video laryngoscopes such as a hyperangulated blade should be able to overcome a problem like that. However, in the situation where the structural anatomy involves asymmetric airway, for example, a hematoma causing shift or tumor where you might have to navigate around the mass, then a flexible scope makes a lot more sense. So I guess it depends on the symmetry of the upper airway obstruction, whether it's very symmetric or whether it's something you'll have to navigate around.
So I think that's something our friend Will Rosenblatt describes as being the sagittal plane or multiplane airway.
Right.
I think we may have overcome any technical issues, and I'd love to hear the end of what Reza has to say about some techniques to buy time. So far, Reza, we've heard high flow nasal oxygen, and if you could just remind me of the types of traumatic injuries that would be a contraindication, in your opinion, to high flow, and then any other techniques that we might consider.
There's only one real or major contraindication, and that is craniomaxillofacial trauma, where you are concerned about base of a skull fracture and pneumocephalus arising from using nasal high flow. I don't know how much of that came through, but it reduces the resistance of the respiratory system by almost 50%. And there's corollary physiological evidence around that in people after extubation. In terms of, nasal high flow is my main to-go-to technique, but recognizing that when you put it on for buying time, you've effectively started a clock. You can't then watch the patient because they've improved on it. You've got to crack on, as it were, and do something definitive. As a surgeon, the other technique that sort of for securing the airway is the straight blade laryngoscope, so surgical laryngoscope, and there are now disposable anesthetic laryngoscopes that are also sort of using the same sort of geometry. I'm a big fan of dual intubation as well, because you can use a hyperangulated blade to achieve partial retraction of the path to intubation, and then use the bronchoscope to go through and find the lumen and intubate.
Thanks. That dual technique that we've heard mentioned once today already, and I'm sure we'll discuss in a little more detail. In terms of other techniques to buy time, in this hypothetical patient that we're following, do you think there's a role for things like steroids, nebulized adrenaline, Are they going to make any sort of significant difference to how long we have to manage this patient's airway?
Indeed, they would have they should have, from a surgeon's perspective, they would have been given before I arrived in the emergency department. You know, absolutely. So that's they will get both of those.
Thank you. We will, in just a second, go to a few more questions from the audience. Just before I do, I'm going to once again throw a what-if question. And Chris, I might direct this to you because you've started to give us a bit of an outline as to what would happen in your emergency department. And I want you to imagine a completely unimaginable situation where your intensive care unit has taken over half your operating rooms to ventilate COVID patients. All of the rest of your operating rooms are full, and it's going to be about 90 minutes before you can get access to a theatre.
Not too long.
So even though you've got that sort of 15 to 30 minute window that John was discussing, we are going to have to stay and play, as it were, in the emergency department. I wonder if you could walk us through exactly what your approach to that would be. Who would you gather? What equipment would you need to gather? And as the team leader within the emergency department, who would you see performing those various roles for securing this patient's airway?
Sure, thank you. So I guess that's very clear. The parameters are that we're not leaving the emergency department to do this. We're going to crack on and do it there. And so then I think there's still an optimal way to do it. And the optimal way would be the right person with the right kit. So we would have an ENT surgeon, if they were in the building, with a surgical kit set up and ready to perform front of neck access. And we would want either the anaesthetic consultant or the intensive care consultant, because they're doing this technique upstairs, to be present with the bronchoscope, the kit they're familiar with, and perhaps with the hyperangulated video laryngoscope as well, and try and do intubation past the level of the injury. So I think that would be the optimal. I guess you could step down from there. So if the ENT surgeon is available, is the general surgeon available? Is the emergency physician comfortable with surgical airways? And I think you just work down to get the most optimal team and set up that you can, given the circumstances and the time constraints, and do your best given that circumstance.
Thanks, Chris. All right, let's see what other questions are coming in from the audience for the panel, and I certainly have a couple related to John's presentation that the audience may be thinking along the same lines that I am. Nick, what's coming in from the audience?
I've got a question here asking John about he mentioned having the ability to perform ATI, and John, you said that was largely what changed was the availability of equipment, being able to plug the bronchoscope easily into the same equipment you're using for a video laryngoscope. Obviously, that's only part of the equation in terms of using those techniques safely and effectively. So, having gotten access to those equipment, the question is, how did you go about establishing training to upskill yourself and your staff in being able to use them properly?
That's a great question. No one really has a lot of experience with awake intubations because we just don't do them that much. And really, in our emergency department, we're doing just a handful a year. Myself, I probably do maybe 3 or 4 a year. So it's not a frequent procedure. So it's really important to gain skills in a non-clinical environment. And we have a simulation lab where we practice fiber optic intubation in the simulation lab. So everyone's at least comfortable with the mechanics of it. The other important thing is we developed a system. Because it's so infrequently done, we actually have a system to facilitate awake intubation in the emergency department. We actually have a glass cabinet that houses our fiber optic scopes and the cables and whatnot that are needed for awake intubation. And in addition to that, we actually have an awake intubation drug box that's stored in a Pyxis. We have a system in the United States where all drugs are locked up and the nurse has to pull it out. And we've actually assembled the commonly used drugs for awake intubation in an awake intubation box. You just type in awake intubation, the Pyxis drawer opens, and a box comes out, and that box is loaded with 4% lidocaine solution, 5% lidocaine ointment. It has glycopyrrolate in it. It has anti-fog solution in it. We recently added Presidex to it. I would have ketamine in there, but ketamine's controlled, so it can't be in there. So we've developed a system to facilitate the ease of doing awake intubation in the emergency department. by having everything in place and ready for you to go when you need to do it.
I think, John, that's a really important point that you've just touched on there. It's more than just about having bronchoscopes available. It's about having all of the kit to topicalize and sedate the patient. And, you know, there's types of situations that Chris alluded to where you might, you know, have an anaesthetist or an intensivist, you know, come down to the ED to perform an awake technique. Inevitably, that ends up with someone running upstairs twice during the process to get a piece of kit that's been forgotten. So I think that's a really important point. You know, when we are setting up these processes, it's more than just the bronchoscope. Nick, can I butt in here just before any other audience questions? I wanted to ask John, if we come back to the crack-on plan that we talked about, so the patient's deteriorated in front of you. Actually, no, I beg your pardon. Let's go to the what if that I posted for you, you know, in this session here. So you have a patient who you need to secure his airway in the emergency department, and I know that you have the ability to do that. But if we recall, our patient was intoxicated at the time of his accident. And he may not be as cooperative as another patient. He might be a bit agitated. What would be your preferred approach in that? So you have an agitated, uncooperative patient, but yet an awake tracheal intubation is indicated and you have the ability to do that in your emergency department. What technique would you use?
Well, in this particular patient, I think the awake techniques can be awake tracheostomy. In a different scenario where the patient was a little bit more stable, not as agitated, not as hypoxic, I might do an awake intubation. And I guess the drug that I would use to facilitate that would be ketamine. I typically use ketamine, 10 milligram aliquots. I give 10 milligrams, another 10, I reassess them. What I want to do is gain control of the patient's behavior without causing airway compromise or respiratory depression. And in the emergency department, the best drug we have available for that is ketamine. So this patient in my emergency department, I would have him on high flow nasal oxygen. I'd probably start at a low flow rate to make sure it doesn't worsen the subcutaneous emphysema. There's some PEEP associated with the high flow, and the higher the flow, the more pressure you get. So I'd be concerned if I just cranked it up to 40 or 70, I might get some subcutaneous emphysema. So I would start at a low flow with 100% FiO2 and then dial it up as I made sure that the subcutaneous emphysema wasn't working. And then I would start administering the ketamine in small boluses to get him in a good state. And I think the safest procedure in this particular patient would then be to get him stable enough to do an awake tracheostomy.
Thanks, John. Are there any other questions coming in from the audience, Nick?
There's just an interesting comment here, I think, just from an anaesthetic perspective, just saying that not many anaesthetists are comfortable either in awake intubation. And I think, Louise, you probably agree with this too, that there's and this was borne out in NAP4, that a lot of times when awake intubation is needed, it's not done because of lack of comfort with the skill. So I suppose my question would be, is awake tracheal intubation and remember, I mean awake tracheal intubation as a technique, not as a device. So not necessarily the flexible bronchoscope, but maybe, you know, awake front of neck, awake supraglottic airway, awake video laryngoscopy. Is this a technique that the independently practicing airway operator should have an awake technique up their sleeve? I'll let you decide who that goes to, Louise.
I think I might ask John for your thoughts on that.
Yeah, well, in the emergency department, we deal with a lot of critically ill patients and are involved in resuscitation. And one of the key components of resuscitation is airway management. And while RSI is a wonderful technique, and I would say the vast majority of patients in our emergency department undergo RSI, probably 99%, I think it can't be your only tool, because there's some patients where RSI is just frankly dangerous. For example, the patient with an anatomically difficult airway, let's say ACE inhibitor-induced angioedema, where putting a patient to sleep and RSI in them is just too dangerous, and awake intubation is needed. And as I discussed earlier, there's some patients with physiologically difficult airways that I feel just can't tolerate RSI, and awake technique is necessary. So I think an awake technique is necessary skill for all airway managers that airways. And it's important to recognize that awake flexible is a whole separate technique that requires a lot more skill. But if you think about it, awake video laryngoscopy is just like RSI with video laryngoscopy. The only difference is the patient's not paralyzed or topicalized. So it's the same skill set, really. You know how to use a hyperangulated video laryngoscope. You know how to do tube delivery. You know how to do the intubation. The only thing you're really adding is topicalization so they can tolerate it and they're not paralyzed. So I think it's very similar to RSI. It's just adding the component of the awake and topicalization to that. So I think most practitioners can gain experience and be comfortable doing awake video laryngoscopy.
Thanks, John. And I certainly agree with Nick that many anaesthetists don't feel comfortable doing awake bronchoscopic intubation. I think many also wouldn't feel comfortable doing awake video laryngoscopy. But the more really wherever we are, we can break these skills up into the components and practice the separate components that we might have more ability to do than have to practice the whole technique in a given patient. Hopefully, we will have access to these techniques to be used in patients just like this when we feel that they're necessary.
So I would say, Louise, as I said in my presentation, I think I would come from the premise that I think it's the patient's right to have their airway secured awake if that's what's deemed necessary for safe and effective management. And I think that puts a duty on us to be able to do that by one of these methods.
Yeah, absolutely, Nick. I completely agree. And, as one of the things we've discussed in this session, it's more than just about providing the equipment, although that's probably a very good and logical place to start. But it really is about bringing together the not only the equipment, but the team and the training wherever the location, as really is the case for whenever you're setting up complex airway techniques throughout either the pre-hospital setting or within the hospital setting. We're going to wrap up this session now. I'd like to thank our three expert panel members. It really has been a fantastic discussion. And I'm really happy to report that our patient has responded favourably to the temporising measures that Reza discussed, including the use of high flow nasal oxygen and as well as some steroids and nebulized adrenaline. He's less agitated, his dyspnea is improving, his oxygen saturations are now 97% with a respiratory rate of 22. In our hypothetical setting, the team have decided that they would prefer to manage this airway in the operating theatre, which is available, and the team to manage is available. So we're going to pick up our patient in the operating theatre in the next session. So to summarise our discussion from this session, we've defined a complex airway technique as one that involves an awake technique, or it involves specialised equipment like a flexible bronchoscope, or it involves a surgical approach. We've discussed that complex airway techniques are possible in the emergency department if they're supported not only by an investment in equipment, but also by robust training, systems and governance. And really they're the same things that we need when setting up complex techniques in any location. And in order to buy time to be able to gather resources or to move the patient to another location, techniques including nebulized adrenaline, steroids, and the application of high flow nasal oxygen can certainly be used.